Next, we have Dr. Irshad Edavana, Phaco Cornea and Cataract Refractive Consultant at Malabar Medical College, Calicut. Doctor will be talking about the evaluation of the cornea before cataract surgery.
No. Yes. Okay. Thank you, Dr. Aisha. So I'm going to present about the corneal diseases and cataract surgery. So as we know, we have to do a thorough pre-operative evaluation of a cornea before cataract surgery, and I will be discussing about the intraoperative and post-operative consideration in this topic. So first one about the dry eye disease. So many of the patients will not have much symptoms before cataract surgery, as we know. After the cataract surgery, they will come back with a 40% session and increase in the symptoms. So all patients, we have to do a dry eye evaluation. Just do a sentinel examination, check for the tear film height, do a tear film breakup time. If you suspect, do a Schirmer, and optometrist will tell you she's not getting the topography or the K1, K2 values before for the cataract evaluation. So this patient should actually do a thorough evaluation of a dry eye. So treat with lubricants, start anti-inflammatory agents, cyclosporin, topical steroids or liftigrast, and treat the lid if there is a evaporative component, and there is a disease, do a punctal occlusion temporarily before the surgery. Intraoperatively, as we know, there will be some dryness on the cornea, apply some viscoelastic over the cornea, minimize the incisions, and put the BCL if required in the postoperative period. Then about the ocular inflammatory disease, we know the disease like PUK, graft-versus-host diseases, JS, Moran's disease, etc. present with the corneal thinning, or some patients have some scars on the corneal periphery. So all these patients, you have to think about the reactivation after the surgery. Always consult a rheumatologist or immunology consultation and start systemic immunosuppression. If you don't have an access to the immunologist, you can start a systemic steroid before the surgery, and ask the patient to bring all the previous investigation papers also. So there should be some quiescent period, pre-inflammatory period before surgery, at least 2 to 3 months, and look for the stem cell deficiency also. So intraoperatively, incision location should be away from the thinned area, and if you expect a corneal melt, always try to take a clearer tunnel for the surgery and use strip and blue if required for the visualization. And wound closure, suture may be necessary near the scarring or thinning area. Postoperatively, close monitor, continue systemic steroid if required. Do not use NSAIDs because it can lead to a little more chance of melt is there, and treat the dry eye and visual rehabilitation after the surgery with a rigid RGP lenses. Pterygium can lead to irregular astigmatism and visual distortions. So during the slit lamp examination, assess the size, location and associated scarring also, and stain the cornea and see extent of the lesion. Do a topography, identify the astigmatism. If the astigmatism is irregular astigmatism and it is encroaching the pupillary area, you have to assess before surgery. And timing of the surgery, that is, you have to first we have to do pterygium surgery or cataract surgery together. That we depends upon the preoperative keratometry value and astigmatism. For a small pterygium which is not causing much astigmatism, we can do combined surgery, or otherwise first do a pterygium surgery, at least wait for 1 to 2 months, then reassess the topography and do the cataract surgery. And for the corneal opacity, see the type of opacity. In these cases, as a slit lamp examination, you can do an ASOCT. It helps us to identify the depth of the opacity and do a topography to see the astigmatism. And if it is less than 100 micron, always we can do a PTK or do a superficial keratectomy, which help us to regularize the cornea and reduce the astigmatism. And for deeper opacity, we may have to do a keratoplasty. So use trypan blue during the surgery. We can use endo-illumination for better visualization, and triple procedure if there is a severe opacity or a large opacity, and a stage surgery if required. Then the endothelial diseases, as we know, we have to deal a lot of Fuchs dystrophy because of these patients come to us at age of 50 or 60 with a cataract. We will be the first one diagnosing the Fuchs dystrophy. So always try to take a pachymetry and see the edema, do a thorough slit-lamp examination, and do a specular microscopy to see the endothelium. So during the surgery, phaco technique should be done, minimize the ultrasound energy, minimize the time, and keep the phaco pieces away from the endothelium. Use adequate viscoelastic, use dispersive viscoelastic, and replenish the AC whenever it's required. And consider a simultaneous endothelial keratoplasty if there is already a corneal edema, or there is a poor view, or if there is we are not getting any values in the specular microscopy, we may consider a combined triple procedure for endothelial keratoplasty plus cataract surgery. And avoid hydrophilic IOLs, because after endothelial surgery we may have to put some air bubble. This air bubble will lead to opacity of the hydrophilic IOL. So do not put hydrophilic IOLs when you plan for a later endothelial surgery. Postoperatively, monitor the edema with pachymetry. You can use hypertonic saline. If edema is not resolving, as increasing, we can plan for endothelial surgery. And try to not to do a gap capsulotomy, because it may also have a large capsulotomy have some difficulty during the endothelial surgery. Then the keratoconus. It may be just a conical cornea or an opacity after the eye drops. So preoperatively take a topo or tomo, check the thinning, what is the minimum thickness of the cornea, do a good refraction. So before the surgery, assess the vision with a rigid contact lens. If it is a young age with a cataract, do a cross-linking, stabilize the progression of the cornea, or do a ring surgery, intracorneal ring surgery. In cataract surgery, we have the issues with the keratometry. So standard device may not be accurate. Axial length, as we know, it will be longer, and effective lens position also will be varied. So selection of the IOLs. So most of the time we choose a monofocal IOL. If it's a regular astigmatism in the central area in the topography, we can go ahead with a toric IOLs. If it's a disease is stable and the patient's age is above 55 and it's a stable cornea, there is no progression, we can go ahead with the toric IOLs. Multifocal IOL generally avoided due to higher order aberrations, and aim for slight myopia. Because most of the IOL calculations give a hyperopic values. So post-operatively aim for a little myopic lens. And intraoperatively, incision location, use pachymetry to avoid the thinnest area. Wound construction, consider the scleral tunnel if it is universally thin, and trypan blue can be used for the visualization. Postoperatively, refraction, it will take time for the stabilization for the final prescription. We can use contact lens if required for the correction of astigmatism, and monitor the progression after also. So residual error can be corrected with a spectacle, contact lenses, or a surgery. So better imaging techniques, advanced IOL formulas like Kane keratoconus formula or Barrett keratoconus formula help us to give a better outcome in the IOL surgeries, and customized lenses. And we have now regenerative therapies in development help us for endothelial diseases. Thank you.